A reading from the Book of Pals to the Frightened, page 290, figure 5.3. Thou have resuscitated thine child, yea, having done so while crying and soaked in thine own urine. The beginning shall now be oxygenation, and it is oxygenation that shall come in the beginning. It is written, thou shalt titrate thine oxygen to a saturation between 94 and 99%. Nay, shalt thou titrate to 93, being too low. Nor shalt thou titrate to 100, being just silly high. In the words of our Saint Valerie, you don't want to get behind the 8 ball on this, Mark. In thine mercy. Okay, so it's pretty clear if we don't dial in our saturations, we're going to go to hell. Next, does this kid need an advanced airway? Are they having issues exchanging gases or maintaining their own airway? So consider an advanced airway. Next, you want to look at their PaCO₂, and if all you have is end-tidal, great. You want to dial in their ventilations to achieve an end-tidal or a PaCO₂ appropriate for their condition. Now remember, this algorithm is shock after ROSC. So we got him back. Now we got to take a look and see if we can identify any of the causes of the initial arrest or why this child is still in a shock state. And we're going to do that by going through the list of H's and T's. Is there something there that we can identify and treat? Now, if the child is hypotensive and their lungs are dry, remember frequent lung sounds anytime you're giving fluids to a kid or anybody for that matter, your initial fluid resuscitation is 20 mLs per kilogram of a crystalloid, usually 0.9. If you suspect this kid has a heart condition, or you know the kid has a heart condition, you're going to cut that in half. Now, if the child remains shocky despite fluid resuscitation, we're going to have to look at maybe giving them a pressor. And now we're going to look at the types of shock that we're going to treat. Okay, box 4, hypotensive shock. Well, it's pretty self-evident. They have a low blood pressure and they're shocky. Cool. If they need fluids, lungs are dry, tank them up, 20 cc's per kilogram, and you can repeat that. If they're still hypotensive refractory to fluid management, then you're going to look at your pressors. Epinephrine, Levophed. And if you look at the dosing of the medications and glean from that, the dosing parameters suggest that we're giving these drugs to squeeze down the pipes to cause vasoconstriction and raise the blood pressure. Again, only after fluid resuscitation. No sense squeezing an empty tank. Next, looking at box 5, it says normotensive shock. And you go, normotensive shock, blood pressure is fine, but they're shocky? Why is this happening? Here's why that's happening. During the cardiac arrest, the child may have suffered some heart damage and have impaired pump function. Their ventricles just aren't pumping out as strong. Meanwhile, you have a low cardiac output, and the body's attempt to maintain blood pressure is peripheral vasoconstriction. So this kid is clamping down on his pipes. So you may get a relatively normal pressure out here. It's not going to last for long because we have a damaged heart with poor ejection trying to pump against squeezed pipes. If they have fluid, we need to open up those pipes a little bit and allow that heart to pump. Again, this should be done under the direction of an expert. You want to get a pediatric cardiologist involved with this patient very quickly. Okay, next, continued reassessment. You're going to treat the child for any agitation or pain. Do they need sedatives? Do they need analgesics? You want to check their blood sugar for sure. You want to get x-ray, blood gases, laboratory reports. And now we got to think about getting this kid out of here. Now, I've been in ERs for years, and I know it's every fiber in your body is going, get this kid the hell out of my ER. Made worse, you call the receiving facility and they go, hang tight, we'll send our transport team. Okay, I've done ground critical care, rotor, fixed wing, and your average great flight team isn't prepared for this. This requires a specialty team. So when you hear, hang tight, we're going to send our team, and you're going, geez, I got flight 5 minutes away, it may be better to wait for that specialty team. Anything goes south between A and B, experience counts. Experience counts. So it may be more beneficial to wait for that specialty pediatric transport team. That's why they exist. I'm Mark. Thanks for watching. See you in the next video.